Hello, people. Inflammatory bowel disease is a group of inflammatory conditions that primarily affect the colon and the small bowel. The main two types of inflammatory bowel disease are Crohn's disease and ulcerative colitis. In order to understand the changes that are happening in the GI tract and in order to understand the signs and symptoms that the patient develops, we need to start at the beginning. And the beginning is the pathophysiology, the etiology, and the inflammatory reaction that is happening in the gut. Three elements are regarded as crucial in the pathogenesis of this disease. The first important element is the commensal microbiome that is present in the lumen of the gut. So if this is the gut lumen, these are bacteria that are present in the gut lumen. In the first 2 weeks of life, this microbiome develops and stays similar through our whole lives. The second important thing is the epithelial cells and the epithelial layer and the mucus layer they produce in the gut. And the third important thing are these immune cells present in the gut. With them, we need to consider also environmental factors and genetic factors. If we now look at all of this, all these factors together, so multifactorial based disease, all these factors together in a susceptible host culminate in a chronic state of dysregulated inflammation. Now, if we have this bacterial pathogen, and if the barrier function of the epithelial layer, like it is here, if it is broken, and if the mucus layer is also broken and ill-formed, the mucus layer has normally two parts. The one part is the superficial part, and this superficial part is actually full with bacteria and loose, but the deeper part is sterile and compact. If the mucus is not produced well, and if we don't have tight junctions, tight connections between these epithelial cells, the immune cells will be in frequent contact with these antigens. Then we also have an immune response developing and happening on these antigens. We have everything. We have a recipe for a chronic dysregulated inflammation. So, for example, if this dendritic cell would take up one of these antigens, and if it would go and present it to this naive T cell, so this is a THO or naive T cell, and if it would secrete IL-12 stimulates the naive T cell, and macrophages that are also present, if they start secreting IL-12, they also influence the naive T cell, and IL-12 also influences the activation of natural killer cells. But now we have the activation of these cells. The reaction can develop in a few ways. All depends on the cytokines that are being produced and that influence the naive T cell. So, if we have the situation where interleukin 12 is acting on this naive T cell, it will differentiate into a T helper cell type 1. The T helper cell type 1 then produces interferon gamma, and this molecule has the possibility to further activate macrophages, to further act immunostimulatory, and it has also an antiviral effect. This path is the proposed path of inflammation in Crohn's disease. Normally, this path our body uses to fight intracellular bacteria. The second possibility is that the T helper cell, naive T helper cell, differentiates into T helper cell type 2. And that happens if it is stimulated by interleukin 4. This interleukin, we don't know which cells produce it, maybe basophils, but we are not sure. And if we then have the differentiation into Th2 cells, they start producing IL-4, IL-5, and IL-13. These interleukins then stimulate the B cell growth, the differentiation from B cells to plasma cells, and IL-5 stimulates the production and the secretion of IgA. Normally, this pathway is used to fight extracellular pathogens, and it is the proposed way that happens, the proposed way of inflammation that happens in ulcerative colitis. The third way the naive T cell, T helper cell, can be influenced is if IL-6 and transforming growth factor beta together, if they act together on this cell will differentiate into a T helper 17 cell. This cell then produces IL-17 and IL-21. These cytokines are pro-inflammatory cytokines. They stimulate the immune reaction. If we have only transforming growth factor beta acting on this cell alone, then this cell will become a T regulatory lymphocyte that produces transforming growth factor beta. So all these cells have these negative feedback loops, and it also produces IL-10. And IL-10 is a strong anti-inflammatory cytokine. So now you can imagine with all these cytokines that are many of them pro-inflammatory, many immune cells start to be attracted and start going into the gut wall from the blood vessels. And the big immune reaction starts to happen. This immune reaction is so hard that it destroys the gut wall and it produces those ulcerations we see. So normally, if you take a histological sample of the gut, normally the gut will have this pinkish color. There will not be many immune cells. But in the case of inflammatory bowel disease, the gut will have on a histological sample a bluish color. There will be many of these cells, and you can only imagine if there are so many of these cells, how many of these cytokines and interleukins they are, and how intensive and severe this reaction can get. Now, we will see what this reaction and this inflammation, where it happens and what it actually does in the gut. So, first, in ulcerative colitis and Crohn's disease have certain differences. In Crohn's disease, or better to say, in ulcerative colitis, as its name suggests, ulcerative colitis is only affecting the colon. And in about 40 to 50%, that is, the inflammation is happening in the rectum and in the sigmoid colon. There is a demarcation, and then we have the normal part. In about 40%, the inflammation goes beyond the colon, and in about 15 to 20%, it's a pancolitis, or the whole colon is involved with inflammation. The second important thing, there are no skipped lesions. The lesions are continuous, there is a demarcation, and then we have the normal gut. In Crohn's disease, we have a difference that Crohn's disease has these skipped lesions. So we have a part of the bowel that is inflamed, then we have a strict demarcation, and then a normal part of the gut. Then we have another part of the gut that is inflamed. In Crohn's disease, we have about 30%, the inflammation is also only present in the small bowel. In about 30 to 40% of patients, the inflammation is present in both the small and the large bowel. And in 50 to 20%, the inflammation is present only in the colon. In about 15% of patients, it is very hard to determine which of these two it actually is. So it is called indeterminate colitis. If we would take a part of these bowels and feel it, it would be actually rubber-like and thick. And that is because a lot of fibrosis and edema are developing in these bowels on the site of inflammation. Microscopically, there's a huge influx of white blood cells, and we have crypt abscesses that are forming. These crypt abscesses are actually developing in the normally present Liberkin crypts. These crypts are starting to be dilated, and we have the influx of white blood cells in them, thus forming these crypt abscesses in Crohn's disease and in ulcerative colitis. If we now would take a part of this gut and dissect it, we would clearly see that in ulcerative colitis, we have this lesion, and then we have the normal part. In Crohn's disease, we have the part that is affected, then we have the skipped part, and then the other affected part. In ulcerative colitis, the inflammation is only present if this orange part represents the mucosa and submucosa. The red part is the muscular layer, and the green part is the serosis. So only the serosis, only the mucoses and submucoses are affected in ulcerative colitis. There is the inflammation. And in Crohn's disease, the inflammation is transmural. It goes through the whole thickness of the wall. Now, if we would take a cross section of this, we can see that in ulcerative colitis, we have actually forming of these pseudo polyps. Pseudo polyps are projecting masses of scar tissue that develop from granulation tissue during the healing phase of the inflammation. So here we have an inflammation and an ulceration. But here, the part that is trying to heal, the granulation tissue, looks like a polyp, thus pseudopolyp. In Crohn's disease, we can see and appreciate that this disease makes transmural ulcers, and thus it is easier in Crohn's disease that fissures and fistules form. Also, in Crohn's disease, fat tissue that is surrounding the gut is moving through the site of inflammation and wraps around it. That is called also creeping fat. Now, if we know all these changes that are happening in the gut, we can start to see and know what is the problem in the patient. So all from this reaction to the changes that are happening in the bowel, we come to the concerns and the problems that our patient is having. On the left side, I will put all the problems that are related to the gut, and on the right, I will put all the extraintestinal problems that arise from this disease. So IBD is not only a problem, it is primarily a problem of the GI tract, but it is actually a systemic disease and a systemic inflammatory condition. So the important symptom is diarrhea. The severity of this diarrhea depends on the severity and the extent of the disease, of course. They can be blood in the stool, blood-stained mucus, crampy abdominal pain, tenesmus, so a feeling that the gut isn't fully emptied, even if you were even 5 minutes ago in the bathroom. Then rectal bleeding. Also, all these problems in the gut, the diarrhea, the loss of the absorptive surface, give rise to weight loss. And the inflammatory condition itself gives rise to fever. The extent of the fever depends, of course, on the severity of the disease. If the disease is very severe, these diarrheas can be a liquid containing only blood, pus, and fecal material. Now, the extraintestinal problems that can arise, the patient can have an inflammation in the eye, uveitis. Also, ulcerations in the mouth called aphthous ulcers. Also, problems with the liver. They can range from a fatty liver or steatosis to a cirrhotic liver. Also, stones that develop, gallbladder stones that can develop. There is also an interesting condition called primary sclerosing cholangitis. This disease, if a patient has this disease, in 80% they have also some form of IBD. And if a patient has ulcerative colitis, in 5% they have also this disease. In kidneys, we have also stone formations, but also frequent urinary tract infections, especially if fistules form, enterovesical fistules, if they're formed between the GI tract and the urinary tract. There are two conditions of the cutaneous system that are linked with IBDs, and that is erythema nodosum and pyoderma gangrenosum. When it comes to the locomotory system, peripheral arthritis is a condition that is linked with IBD, and also loss of bone mass. Patients with IBD have also a higher risk of developing deep vein thrombosis. So we can really see that this disease can cause many problems. There are certain clinical differences between ulcerative colitis and Crohn's disease. Because ulcerative colitis is primarily affecting, or it is only affecting the colon, but Crohn's disease can affect all the parts of the GI tract, from the mouth to the anus. So in ulcerative colitis, we will have a diarrhea with rectal bleeding, broad-stained mucus, tenesmus, abdominal pain. But in Crohn's disease, we can have other symptoms, and the site of the disease influences the clinical presentation. So for example, if we have ileocolitis, so a disease that is affecting primarily the small bowel and large bowel, we will have a history, and it is concentrated in the terminal parts of the small bowel. We will have a history of chronic recurrent episodes of right lower quadrant pain and diarrhea. Initially, it can also mimic an appendicitis. Secondary, if we have a ileitis, so primary inflammation in the small bowels, we will have loss of the digestive and absorptive surfaces, which can lead to intestinal malabsorption, which then presents itself with severe diarrhea, weight loss, anorexia, anemia, and so on. If we have colitis and perianal disease in Crohn's disease, the symptoms will be similar as ulcerative colitis, but we will have also anal fissures, fever, abdominal pain, and so on. If we have gastroduodenitis, we will have nausea, vomiting, epigastric pain. So the site of the disease influences the clinical presentation. Also, in regards to complications can go into two ways. There are two patterns of development. One is fibrostenotic, obstructing. In this pattern, we have fibrosis and obstruction. If this fibrosis and obstruction is severe, it needs to be treated surgically. The second is penetrating fistulas. Pattern. In this pattern, we have the penetration of the gut wall and forming of fistulas. We can, for example, have enterocutaneous fistulas, where the gut is connected to the outside. We can, for example, have rectovaginal fistulas, where the rectum is connected to the vagina. So these complications need to be treated surgically. Also, colon carcinoma, people that have IBDs have a higher risk of developing it. And in a differential diagnosis, there are two possibilities. Either we look on infectious diseases, and the second is non-infectious diseases. An infectious disease, a bacterial colitis, will have the similar symptoms. And when it comes to non-infectious diseases, for example, diverticulitis, ischemic disease, radiotherapy will have some similar symptoms. So all in all, this is a very horrible disease, and it can have very hard and severe complications, and it can ruin the patient's life. Thank you.